Yes.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, everyone. I hope you enjoyed the previous session. With you is Abir Mahanna, a clinical pharmacist by background and a specialist, a patient safety senior specialist at Saudi Patient Safety Center. And I will be the moderator of this session today. So our session today will walk you through the implication of digital health and documentation for the quality and safety of diagnosis. And this session will walk you through several topics, starting from artificial intelligence and clinical decision support system, ending with the clinical documentation importance for diagnostic safety. Before we start, I would like to remind you all to keep your question in the Q&A tab at the end of the platform. Also, I would like to start and welcome our first speaker for this session, Dr. Hisham Al Omran. Dr. talk about sepsis, early detection and diagnosis. Dr. Hisham is a consultant pediatric emergency at King Faisal Specialist Hospital and Research Center. He is a chief quality officer as well in the King Faisal Specialist Hospital, with a master's degree of public health from University of Kansas, USA, holding a certification in certified professional in healthcare quality, and a current board member in Saudi Red Crescent and current board member in MOH Al Qasim cluster. So welcome, Dr. Hisham. The mic is yours.
Thank you very much. And first, I'd like to thank the Saudi Patient Safety Center for organizing this very important event and this conference. And I'd like to thank them specifically for giving me the chance to present to you today. And I'm hoping that you will find this useful for you as you continue to focus on patient safety. I'd like to start by talking about, I'd like to go to the first slide. I'm not sure if you can see my first slide. I'll be talking about sepsis early identification and diagnosis. You cannot see my slide? Just 1 second. Just give it 1 second to open. So can you see my slide now? Okay. So I'll be talking about sepsis and the importance of early detection and diagnosis. And I'll be focusing on first at the burden of sepsis in healthcare. And I will walk you through how to develop a sepsis early detection and management driver diagram to help you to think about the main issues you need to deal with when trying to identify patients with sepsis early. And I'm also going to share my experience of King Faisal of implementing a 3-phase early sepsis response program. And I'll share with you finally the lessons that we learned from our journey in terms of improving sepsis care. So first, I'd like to start with some facts about sepsis. As physicians and clinicians, you all know about sepsis, but I think many of you will be surprised that sepsis by itself accounts for about 20% of all deaths in the hospital. And recently, in 2017, it accounted for 11 million deaths worldwide. And interestingly, one of the most affected areas is pediatrics, with 50% of all sepsis cases. Now, why is this important for us as quality practitioners and as the patient safety, as advocates for patient safety? Is that sepsis is a preventable, or mortality from sepsis is a preventable outcome. So we really need to focus on why do we not always approach sepsis early enough, quickly enough, and aggressively enough. And what we do are three main drivers of reducing sepsis mortality. The first one is early detection. The second one is early intervention. And the third one is a standardized response to sepsis. So we'd like to start with a problem statement. This is something that very important for us to focus on, because unless we all agree what's the problem or we've identified as a problem, then it makes it hard to decide what's the best intervention. And what we noticed is, even though we had built a very comprehensive severe sepsis alert trigger in our electronic medical record, and we believe we were very advanced in doing that, we noticed that more recently we had multiple events of delayed recognition of patients with sepsis. And we also noticed that when there was detection, that has led to bad or poor outcome. And we noticed that from our quality information system, our QIS system, where we log in all incidences that happened related to patient safety and patient care. And our team in the patient safety section identified this as a trend where we were commonly delayed in managing who were later known to be septic. So what we did was we did some baseline data assessment, and what we found was that although the electronic trigger was activated, we had multiple episodes where there was no response. And so even if there was a response, there was a delay in response where, as you know, the goal is to give antibiotics very quickly. And we found out that there was a delay in giving antibiotics to these patients, which led to two main outcomes. One was that their ICU length of stay was prolonged up to 18 days. And secondly, the average mortality rate was very high, 22.9% for all inpatients. So what we did is now that we've identified the problem and we have some baseline data, we then went and worked on this driver diagram. And for those that are not familiar with the driver diagram looks at the main drivers for the problem. So on the left side, the problem is the delay in management of sepsis, and the four rectangles in the middle are the drivers. Why do we have a delay in sepsis? And so the first one is a lack of a reliable recognition, which is an early warning system. Second is a lack of an assessment screening process. Third is variation in the sepsis management. And fourth, and probably most importantly, is the lack of awareness of sepsis. It's very easy to diagnose sepsis when it's very late, but it's not easy to diagnose it when it's very early. And this is a really difficult part. We don't want to wait for overt signs of sepsis to start sepsis, because we know that that's when the worst outcome is going to happen. And so once we've identified these four drivers, we looked at all the things that we could do to reduce or improve those drivers. So if you look at just, I'm not going to go into all the details of these, but if you look at just the awareness and education, we did multiple things. We highlighted sepsis at the gatherings, whether it's the safety huddles or the ground rounds. We applied visual management systems to showcase the sepsis. We shared brochures about sepsis with the staff. We built an education tool into the orientation program for departments, as well as what we have is an online portal specifically with this. And finally, we actually trained the nurses to be able to better identify sepsis. And finally, we used our newsletter to share information about sepsis. We have done certain things before, and I'm sure many of you have in your own institutions have done similar kinds of things, but we felt it was important to link it all together with all the other drivers so that we tap for more than one direction. So that was the driver diagram we based everything from. And so part of that was we looked at establishing an algorithm, an automated, validated algorithm to pick up patients on sepsis. What we noticed is that as much education and awareness we provide for the busy nurse at the front, is that after time, the focus on sepsis will decrease. And so from the literature and our own experience, we believed that having an automated algorithm and a trigger would work for us. From that, we created a dashboard. And in addition to that, or built on that, we actually dedicated one nurse team to be purely just looking at the dashboard and going to the respond to the patient side. And finally, we standardized the sepsis care. So
what's the tool that we
used? It's a validated tool. We didn't create something from our own. We used what was already been created, which is what's called the Quick Sequential Organ Failure Assessment Score. And basically, it's the advantage of it. It's quick. It just looks at three main things: the respiratory rate, pressure, and the level of consciousness. We liked it because this is the routine that the nurse would do at the bedside. It did not require any further labs or investigations, and it did not disrupt our current flow of care for our patients. Secondly, or with that, we actually established quite a large team, a multidisciplinary team of healthcare practitioners. It included physicians, nurses, pharmacists, QM experts, but very importantly, it also included non-clinical, such as IT, because a lot of what we were doing was going to be changing the workflow of our patients, and we were going to be using digital technology to better pick up and diagnose patients. So we mapped out the sepsis response project, and we put KPIs and timelines and targets for each one of the components. So starting from the left, the nurse responder who actually gets the initial response, to the nurse who arrives at the bedside, we expected that whole process will not take more than 10 minutes. In addition, we asked the physicians to respond to the nurse and come to the unit within another 10 minutes. And so the hope was to complete the whole cycle about the sepsis initial approach within 60 minutes, which is consistent with the literature. And then we basically went through every single healthcare provider and their role, and we actually set their job description and put targets for what and when they're supposed to do it. So if you see here, The first responder nurse was going to look at the triggers in the dashboard and communicate to the second responser nurse within 3 minutes. The second responser nurse had to attend to the bedside within 10 minutes and complete the documentation and make a decision whether this was a real trigger or not. And then the physician's role was to come within 10 minutes and assume responsibility for starting the sepsis protocol. Now, we did not want to leave the bedside out of this because we know that they really wanted to be involved in the patient's care. And so their job was clearly defined in terms of documenting, in terms of helping to start the process for sepsis care, and also to enter the parameters for the sequential score for QSOFA. And this is how we would do it. We would document into the electronic medical record. We would put in the respiratory rate, the blood pressure, and the level of consciousness. And then on, it was an automated process. The thinking and anxiety out of the process. So the bedside nurse, once they enters that, there would be a trigger that says this patient is at risk for sepsis because their score is 2 or more out of 3. And that automatically sends the alert to the dashboard nurse. Starts the process. The reason we put that in, because if you remember in the baseline data, we had many times when the nurse at the patient's bedside was either too busy or didn't identify this patient as septic, even though the vital sign parameters were abnormal. And even though the trigger notified the nurse that this patient was at risk for sepsis. So again, just to go, we actually converted this into a policy and put it into our standard policy for management. And we set, like I said, targets for each of them, and we monitored each component of this as we went through. This is what actually the dashboard, what the electronic medical record would look like. So on the bottom right, this is where the nurse would enter their information about the patient, and they put in the 3 parameters. On the left is where the nurse would see the actual in many departments. If you can imagine approaching a patient who's potentially septic, we would have respiratory therapy, pharmacy, nursing, physicians that were not necessarily at the bedside. So we had to have a process for all of that, and triggers when we would escalate. So it linked in with our escalation policy as well. Again, this is a more clear description or image of what the sepsis dashboard looks like. This has every single patient in the hospital, and if their score is 2 or more from 3, they would pop up on the screen, and immediately the dashboard nurse would be responsible for activating the sepsis response nurse. Again, the roles and responsibilities for each person, as I said, it not only was physicians, it included the lab tech, respiratory therapist, radiology in certain times when we wanted to do an urgent chest x-ray, for example, and the critical person would be the person who sends the samples or delivers the samples to the lab. So we did this as a pilot, and we piloted this in March until May as a phase 1. I'll share with you some of the data about that. And the objective was to then expand that pilot to other areas. And because we have more than one hospital, ultimately we wanted to consider, if it succeeds, to expanded to 3 hospitals and to all age groups. So this is some data from our actual study. We had in this period from June to August, the qSOFA score was activated 179 times, but actually some of them were the same patient. And when we excluded some of the DNR patients, this is the data that we had. We had 65 real sepsis alerts. Of those, 62% of those were confirmed sepsis by the nurse. And from that, we later got confirmation that 9 of those truly did have sepsis. And from those 9, we're happy to note that we didn't have any mortality. We did have 2 that needed to go to the ICU. And we looked at compliance. We wanted to make sure that how compliant were the nurses in terms of doing the screening. And so the baseline data before was the compliance was 64, but once we started the training program, the compliance reached up to 98%. And documentation by the nurse responder also improved, but of course, it's still not at the level where we want it to be. So the baseline sample was before we started was that we had looked at 3 units between January to February of 2021, and we compared that to the same 4 units from June to September of 2021. And what we found out is, although if you look at the bottom line, the bottom bar, the baseline, there were 13 total patients who were identified as septic in the first group, and 4 of the 13, unfortunately, had a death. While when we did the pilot in the group later on, in the same type of patients, in the same number of patients, we did identify 9 patients with sepsis. And because we reached them earlier and we started antibiotics earlier and we had an autumn, there were no mortalities in this group. We also looked at, we know that we had some patients that did go to the ICU. So we looked at comparing the baseline group and the pilot group about how many of them, how long they stayed in the ICU. And before we started the pilot, 4 days was the average number of days for a patient to be in the ICU. After the pilot group, the number of days was 2.5. And we think that was because we identified them quicker. So we're able to get treatment started quicker, shortening their total duration of stay in the ICU. Maybe they're a little bit less sick, but what we know is that none of them actually did die. And we looked at multiple process measures to make sure that we were hitting our targets. So as I said, our goal was for the nurse to be there within 10 minutes. We were able to have, on average, the nurse there within 8 minutes and 31 seconds. We wanted our physicians to be there within 10 minutes. They were a little bit beyond that, on average, at 14 minutes, 9 seconds. We wanted to give the initial fluids within 60 minutes and the antibiotics within 60 minutes as well. As you can see, we didn't quite reach those targets for both the IV fluids and the IV antibiotics. And so we looked at the sensitivity and specificity of the qSOFA tool, and it really just confirmed that what we know is that it's a more sensitive tool. So if you look at the right side, out of all the patients who had the trigger, only a small percent actually needed ICU admission. While in the previous tool we used, a significant number of them needed to go to the ICU. So we think that's because they were more sick and treated and managed a little bit less quickly. Again, this just shows the same really data that when we go in the pilot group, when we go to see the patients, 22.5% of them have sepsis, while in the group before, the baseline group, 50% of them have sepsis. So that tells us that we're actually identifying the patients initially at a much later time. So that's why they are more likely to die or more likely to have a longer ICU stay, because we're identifying them later. So what we like to do is to learn from all of this and link it with the high reliability organization principles that we apply at King Faisal Hospital. And so we focused on the HR principles. So we were really preoccupied with failure, and that's why we started with a pilot. We started with a very broad team, and we spent a lot of time preparing that team, because we wanted to make sure that, first of all, we're not going to harm patients, and we're going to do it well. And that's consistent with the principles of preoccupation with failure. We were sensitive to the operations because we identified that commonly patients with sepsis are delayed in terms of their management, and we wanted to act upon that. We deferred to expertise because we really did a lot of research looking at the various tools of multiple multidisciplinary committees look at this. And we always included our experts from infection control and infectious disease and pharmacy in helping us to develop this. We wanted to be also resilient. And so as we progressed, we modified the process based on the feedback. So we sat with the residents, who were the main people involved in this, and learned from how they suggested we could improve it. And we were very reluctant to simplify. At the same time, we didn't want to make it perfect, so we really got the support from our leadership to try it and modify it as we go forwards. And so finally, what we learned from this, the development of the EMR and a dedicated nursing team was able to identify patients that had been missed, and we were able to start therapy earlier. And now our goal is really to expand to other sites, age groups, and also to learn how we can consolidate our practice more. And we're looking to develop, instead of a sepsis team, we're looking to develop what's called a medical emergency team to oversee all patients at the hospital. This is just the final slide of the main, kind of team members from multiple departments, and the evidence wide awareness that was done as part of this sepsis early recognition project. I thank you for your time. I'm available for any questions at any moment.
Thank you very much. Thank you very much, Dr. Hisham. Very informative and eye-opening session, highlighting how the early detection of sepsis can really save lives. We will keep the question at the end of the whole session. So we will move on now to the next speaker, Engineer Ahmed Al-Garni. Engineer Ahmed Al-Garni will talk about adoption of new technologies to improve diagnosis. Engineer Ahmed is in the medical device sector at Saudi FDA with bachelor degree in biomedical technology from King Saud University. He joined Saudi FDA at 2011 as a director of the medical device surveillance department. He worked before at King Abdulaziz Medical City for National Guard for 10 years as a biomedical engineer. Welcome, Engineer Ahmed. The mic is yours.
Thank you, Dr. Abir, for the introduction, and thank you for the Saudi Patient Safety Center for the invitation. I'll be talking to you about the I'll be talking to you about the importance of the adoption of new technology to improve diagnosis, safe, effective, and efficient care. Start with the right diagnosis. Technology in healthcare continue to shape the way we provide the care to the patient. I am projecting. As we said, the technology in healthcare continue to shape the way we provide care to the patient. And with the advancement in AI and the data generated from wearable and smart technology, also the involvement of technology companies such as Google and Apple and other companies, this all hold a great promises to improve clinicians' ability to diagnose and treat patients, as well as improving the quality and safety of care. But however, safe use of technology and using technology to improve safety require careful consideration how it will be integrated into clinical diagnosis processes, and how it can enhance communication between patients and clinicians. Here are the topics that I'll be covering today. I'll be talking about the importance of technology in healthcare, also some of the drivers for diagnostic quality, and the challenges facing the technology in healthcare. Also, I'll be talking about the AI in healthcare, and I'll give some examples. First of all, the role of technology in healthcare. Here, the primary goal of any technology innovation is to optimize the current system and to help the physician ease their work and overall improve the patient care. Doing this also by reducing the cost and ensuring the seamless experience for all involved parties. Here we can see listed of some technology that have changed the face and how health industry are working. First one is the big data. Big data can help in many ways. It can help, for example, it can help in better hospital staffing by studying the current admission rate, and it can help the administration predict the future admission rate. Also, it can help in reducing the medication-related error by studying the analyzing and studying any gaps in the between the drugs and the condition of the patient, and also it can alert the doctors of any contradiction. Big data can help streamline a lot of regular processes, identifying of and alerting any gaps that may cause any hiccups to patient care. The second one is the wearable medical device. And back in the days, a patient will go to the clinics when there's something wrong. But in the age of information and technology, patients are keener to on prevention and maintenance, and they are keener also for demanding more information about their health. And that's why healthcare companies are being proactive and investing in this technology, in the wearable technology, that can provide up-to-date information on the patient condition. For example, the exercise tracker and the heart rate sensors. The third technology is the virtual reality. It holds a special place when we talk about the importance of technology in healthcare. Some application, for example, the use of VR for virtual reality in reducing the pain or controlling the pain. Some doctors are some doctors are researching the use of virtual reality to ease the pre-surgery anxiety. Also, it will help doctors to plan for the complicated surgery, and it also help them to refine their skills. Also, the third one is the blockchain, which is a database shared across networks of computers and allow hospitals to share financial information within their suppliers in secure environment.
Engineer Ahmed, excuse me.
Yes.
Yeah, the slide is not moving. Can you just move your slides, please? Sorry to interrupt you.
It is. Can you see it now? Or? Oh, all right. So carry on. We also we are talking about the blockchain and how it can play a key role in keeping financial record and electronic health record accurate and safe. Also, we'll talk now about the telehealth, and which is the surface become in the forefront in the 2020 as COVID-19 pandemic introduced a new way of seeing patients. Even before that, the telehealth was beneficial for patients who live in a remote area and they cannot travel to see their doctor. So this is also a new technology that can help and improve patient care. So in conclusion, there's no debate that about the importance of technology in healthcare. With the advancement in big data and wearable medical device, VR and blockchain and telehealth and more, healthcare practitioners are in a much better place to manage their patients. The technology have refined the process from predictive to preventive healthcare management. Now the objective is how to offer the best possible care and give enough information to the patient so that they feel empowered about their health. Here are the drivers for diagnostic quality. As you know, the diagnostic process can be complex, so technology intervention can improve the diagnostic quality and safety, and it must not consider the cognitive factors, but also the system factors. And here are the drivers for the diagnostic quality. And it was also presented yesterday by Dr. Salvador. And so I'll just go through them quickly. It's the first one is the effective teamwork, which is that the team must apply a safety culture principles and practice focus on active communication and engagement with patients and families. There must be a processes and technology and tools to support and ensure effective communication among care team members. The second one is a reliable diagnostic process, which is a system of people and process and environment that achieve accurate and timely and communicated diagnostics, which refer to organizational structures that optimize diagnostic safety, clinical operation, and workflow. to support the accurate and timely diagnosis. The third one is the engaged patient and family members, which is the action taken by the patient and family member working in partnership with the team. Engaged patients are empowered to participate in the care and practice and participate also in shared decision making related to their health. The fourth one is the optimizing intellectual performance, which is the supporting the process of clinical reasoning, including the integration of clinical knowledge and information derived from patient, family, or other member of the care team. Also, the robust training system, which is the structures of and process of creating and retaining and transforming knowledge within the team. Now we will move to some of the challenges for technology in healthcare. The first one is security, as security is a primary concern in health application, as they often deal with confidential and sensitive patient information. Also, the data privacy and regulation. There are a number of laws and regulation surrounding the patient documented rights, including how providers share information. Such regulatory measures put a burden in data fluidity and make it more difficult to adopt new technology. Also, the regulation are not just one size fits all. There are the data protection and the legislation are different between countries. Also, the simple user experience, which is it's the most important thing when organizations are considering changing or adopting a new technology, because the technology, to be truly successful, it must be user-friendly. Last one is high-performing, high-quality solutions, which is, of course, it's a real-time communication and require robust application performance and quality of services, as the caregiver need access to reliable, high-quality video, audio, imaging, and patient monitoring data. And now move to the artificial intelligence in healthcare. It's become ever present in modern business and everyday life, and also being applied to healthcare. The use of AI in healthcare has the potential to assist a healthcare provider in many aspects of patient care and also administrative process. Let's take a look to a few different type of artificial intelligence used in healthcare. The first one is the machine learning, which is one of the most common forms of AI in healthcare, and it is a broad of techniques at the core of many approach in the AI, and it has many versions. One of them, the most famous, is the precision medicine, where is a drug and treatment designed for a small group rather than whole population, based on the characteristics such as medical history, generics, and other factors. The second one is the natural language processing, or NLP, which is it include a form of speech recognition or text analysis and then translate it, and it can also the application that can understand and classify clinical documentation. It will analyze unstructured clinical notes on patient giving incredible insight into understanding quality, improving method, and better results for the patient. Also, the diagnosis and treatment application. AI can help with the diagnosis and treatment applications, not as a replacement for physician, but to support their decision to make better recommendation based on analysis of a large number of data. For example, the electronic record, the medical imaging, and the doctor reports, and other. So looking forward, the greatest challenge in AI in healthcare is not whether the technology will be capable enough to be useful, but ensuring their adoption in daily clinical practice. Now we give some example that I found interesting. I mean, during my search and I'm sure you are using and know more application of this innovative and new technology. I start by this example, which is the launch of AI-based breast cancer detection program in KSA, which was announced 2 months ago by the Ministry of Health in Saudi Arabia, and with collaboration with Saudi data and AI authorities, SDAIA. The aim is to improve the and build on the project of breast cancer early detection that was launched 2020 to increase the early detected cases on breast cancer and to reduce the mortality from breast cancer. And also this program aims to improve the quality of diagnosis and to reduce error and increasing the efficiency of physicians to tackle this disease. The second one is the artificial pancreas or bionic pancreas, which is a closed loop control system, consists of some components that will control, track person blood glucose, then automatically deliver the insulin when needed using an insulin pump. As you can see in the illustration here, that it has some components, the continuous glucose monitor, which will measure the patient blood glucose through a sensor placed under the skin. Then it will send the information to a controller, which has a software to analyze and to mathematically calculate the right dose based on the information received from the monitor. Then the insulin pump will just infuse, adjust the insulin deliver to the patient. Of course, patient is part of the system. Also, this is another example of the technology, which is an in-home study that done for Parkinson's disease, which is the fastest growing neurological disease. It is affecting more than 10 million people worldwide. So in the effort to address this problem, researchers from MIT and other institute are demonstrating an in-home device which is like it's about the size of a Wi-Fi router. It will evaluate the Parkinson's severity and the progression of the disease and how the patient responds to the medication, also by monitoring the patient movement and guides speed. The researcher used this device to conduct a 1-year at-home study with 50 patients. And by using this machine learning, they can analyze the data and can improve the effectively, and they will improve the patient and continuously monitor the patient and how he is receiving the medication. Also, one example, which is an interesting one for me, which is a doctor prescribed video game treatment for kids with attention deficit hyperactivity disorder, or ADHD. It is for kids from age 8 to 12. It delivers through an immersive video games experience on mobile device. It is an FDA authorized medical device, and it is not intended to be a standalone therapeutic, nor it is substitute for child medication. Also, this is an interesting technology, which is a research study on a mice, where they put a sensor that can, a nanoparticle sensor that can distinguish between viral and bacterial pneumonia. The sensor can, it will help doctor to choose the appropriate treatment. And doctor and researcher showed that with only the sensor can accurately distinguish between viral and bacterial pneumonia from using a simple urine test, and can be read within 2 hours. By using this diagnostic, doctors could avoid prescribing antibiotic in cases where they won't be effective. With that, I come to the end of my presentation. Thank you all.
Thank you very much, Engineer Ahmed. This is a very rich learning opportunity, and you highlighted how the technology can help in bypassing or eliminating the human errors, especially the slips and lapses, and improve the quality of diagnosis. Thank you very much. And now we will move to the next speaker, Dr. Khulud Al-Gharabli. Dr. Khulud will walk us through the clinical decision support system that is implemented in WASFATI program. Dr. Khulud is a pharmacist with 15 years of experience in the hospital pharmacy, and she is the service operation manager at NEPCO, the National Unified Program Company. Dr. Khulud, the mic is yours.
السلام عليكم جميعا. أنا الدكتورة خلود الغرابلي Operation Service Manager in WASFATI NEPCO. So first of all, I would like to thank the third SPSC Patient Safety Committee for giving me the opportunity to participate in this conference. Today we are going to discuss WASFATI clinical safety measures and our system, clinical decision support system at WASFATI. First of all, as a beginning, I want to give you a few introduction about WASFATI patient journey, especially starting from the registration, prescribing, patient receiving the e-prescription, then go to any community pharmacy and take his own medication. So WASFATI is an electronic platform that aims to provide a highly efficient healthcare services and maintain the drug availability through the primary healthcare and hospitals with community pharmacy, so the patient can go to any nearest pharmacy and pick up his medication. WASFATI is an e-prescription solution able to minimize the prescription error and improve the patient medication adherence. As you know, through this journey, a lot of increasing adoption of electronic prescription and dispensing system have driven a wealth of interaction and patient healthcare professional and system perception of medication safety risk. So medication error and adverse reaction are commonly caused and clinical important problems. Medication error could occur in any one or any stage of those, starting, as I told you, from prescribing, prescription, transcription, preparation, and administration. And this is the journey of WASFATI. WASFATI team is considered national and international standard, best practice for clinical, businesses, and technical guidelines. WASFATI aligned with national standards related to prescribing and dispensing standards to its provision. This is an example of national standard that we have, such as CBAHI standard, ISMP, which include the LASA, segregations by using the Tolman lettering in the system. Also, WASFATI have a safe prescription for no abbreviation used, and even a comma for the 1,000 expressed in number. Also, WASFATI has the NOISH standard, which is appear as example here, the hazardous and the high alert medication. Also, WASFATI using the standard terminologies with WASFATI for disease, such as ICD-10, Allergy International determines global standard for health terms that improve the clinical integrity and tracking for clinical benefits and value. WASFATI enable other safety measures, especially at the dispensing side at the pharmacy. So we should be ensured about the correct medication that to choose and the instruction in the printed label for the patient. So the printing label should be in both Arabic and English, sending SMS for the medication and instruction both in Arabic and English, provide the service for medication reconciliation that the practitioners can see or check the patient history before prescribing or dispensing. And we have a refill notification on our system. So clinical decision support system, it's a provision of knowledge targeted a lot of information to the clinicians and staff and patients at the right time to enhance the patient healthcare processes and avoiding the errors and adverse events, improve the efficiency, provider and patient satisfaction, reduce the cost by choosing the best cost of the medication, high integrate evidence practice into the healthcare delivery. CDSS and WASFATI improve the medication safety and reduce the medication-related expenditures by including computerized reminder and advice regarding the drug interaction, the drug, the dosage, the duplication, the drug-drug interactions, the drug-disease interaction, the drug allergies, drug age, drug pregnancy, and drug contraindications, etc. So our system is currently in-house CDSS. It's enable industry stakeholders to check and alert on potential mistakes and review in medical coding and monitor drug safety and medical necessity. The system has been built also to cater all the local settings, including the localized medications, such as the approved SFDA medication, on prescribing level by having a most common use for the practitioner or the user list. At the pharmacist side, there is a common list that appear to the pharmacist to decrease any medication error happen to the patient. Also, the system is totally independent and is based on guidelines from recognized bodies such as the Micromedics, the Lexicom, the First Data Bank, the local authorities, and other recognized societies. There are two types of CDSS in WASFA, the passive and the active. The passive is design features and computerized provider order entry that lead the users or the practitioners to do the required action. The active, it's the design features and the computerized provider order entry that alert or notify the users of the action on the system. There's some examples of the passive CDSS and WASFA by limiting the drug list based on the location or services that we are, which is required from the MOH or the primary health care. Filled for order components such as the dose, the route of administration, the frequency, prioritize the list of the pharmacist side by choosing or selection the best cost-effective medication and integrated the evidence-based, incorporate calculation. The active type on CDSS is going into two types, asynchronous versus synchronous. The synchronous, it's a flag that appears to the patient list as a notification based on changing patient condition, like a new allergy added. And this type, it's non-interruptive the user, so he can add the new allergies that he or comments he want to add. The synchronous type, it's a pop-up notification and alert which required an action such as drug allergy or drug interaction. And this type, it's typically interruptive the user or the professional. So he cannot go to the second step without going through the action. This is an example of alerts generated from the CDSS system in WASFA. As a medical warning details, you can see on the first one, it's showing the indicated to diagnose, not indicated to the diagnosis. The second one is a contraindicated on the system. There's other example also of alert generated from the CDSS system in WASFA. The first one is a duplicated therapy. The second one is a wrong information in prescribing. So WASFA system impact on medication error, prevention and cost benefit. This graph illustrates different types of alerts that appear on our CDSS system. And here you see the blue icon is number of alerts, the orange is the overridden alert since WASFATI started. This is an example of a drug-drug interaction. So our WASFATI system, since it started in May 2019, the average prevention rate was in WASFATI is 71.88% from 1,673,377 alerts from all total drug interaction, which those alerts triggered on 342 patients. Other example for drug allergy interaction also, it shows that the alerts are triggered on 680 patients. So our system prevention rate was 65.87% from 10,560 total drug allergy interaction alerts triggered. This is the number of triggering percentage. Drug disease contra. Okay, in drug disease contraindication, it shows since 2019 also that 81.84% from 2,072,363 drug disease contraindication alert from 337 patients or prescription. Drug duplication also, it shows 77% from 23,309,484 alerts. Those alerts are triggered on 932 patients. Drug age and drug gender also showing 52.97% of prevention from 627,431 total drug age and drug genders alert from 186,698 patients. Drug overdose, here you can see that 100% of prevention happened in WASFATI because WASFATI system it's blocked the drug overdose. So from 59,771 patients, it was 100%. So the alerts, it was 0. Duplication or double doctoring, doctor shopping, WASFATI prevent dispensing 4,301,000 prescription or drug orders since it started. End of 2018. So our system here, you prevent the use more than 150 obtain prescription for greater amount of medication at dispensing side, which call refill too soon. This order refill too soon, we are stopping any duplication therapy from the pharmacy side until we make sure that 80% of other prescription is consumed or dispensed. So the upcoming improvement to WASFATI services, patient education material on SMS inside the medication detail, warning label, medication images in SMS, maximum single dose, narcotic uncontrolled medication prescribing and dispensing approval process, restricting medication by specialty level and medication specialty, barcoding scanning, and one-time password to the patient SMS. This is all the features upcoming, inshallah, in WASFATI services. Thank you so much.
Thank you very much, Dr. Khulud, for introducing this very high-level application and its importance in reducing diagnostic safety events. Dr. Khulud will not be able to join us at the end of the session for the Q&A, so please send your question to the conference email, speak@sbscconf.com. So our next speaker will be Ms. Nicole Draper, talking about the documenting diagnosis and patient safety. Ms. Nicole is her passion is partnering with hospital, improving clinical documentation and empowering clinicians to deliver safer care. Ms. Nicole is regarded as Australia's foremost clinical documentation specialist and a co-founder of CDIA. She is focused on patient safety, data integrity, and financial sustainability through clinical documentation improvement. Ms. Nicole have a bachelor degree of nursing and master's in health administration and graduate certificate in research. Ms. Nicole is joining us live from Australia. Welcome, Ms. Nicole. The mic is yours.
Good afternoon, everyone. It is my absolute delight to be with you this afternoon. We're just getting my slides set up so that I can take you through. Share screen. And if I could just have someone confirm that you can see my slides. I'll just move backwards and forwards.
Yes, it's clear.
You can?
Yes.
Excellent. Wonderful. Thank you, Dr. Abir. First of all, thank you so much to the Patient Safety Centre for inviting me to be a part of this conference. My colleague, Dr. David Trelagan, actually spoke at the first patient safety conference you had a couple of years back in person in Riyadh. So we're absolutely delighted to be a part of this again today. Great to have seen the previous speakers, and I feel that what I'm going to be sharing with you today really does connect with each of those previous speakers this afternoon. So as Dr. Abir said, I'm Nicole Draper. I'm from Clinical Documentation Improvement Australia. I'm a nurse by background, a clinician. Our whole team are clinicians, and we're really passionate about working with hospitals, across Saudi, across Australia, to really improve the way in which we document in the medical record as clinicians. So we do lots of training and education on clinical documentation improvement. As I say, our whole team are doctors and nurses. And that's a really special group to have because, as clinicians, particularly our doctors, junior doctors, know all too well what it's like to be working in a very busy hospital and feeling as though perhaps the care you're delivering isn't as safe as it could be for a variety of reasons. So we're really proud that we're able to be change makers and to be able to really influence the way in which clinicians document in the medical record. So our mission is to empower clinicians to deliver safer care to every patient. So when I was invited to speak at this conference, I thought, there's no greater synergy really than what the Safety Centre is doing and what we're trying to achieve as well. The way we really make sure that we are empowering clinicians to deliver safer care to every patient is by creating a documentation culture that reflects the clinical truth. So that's making sure that every time a clinician documents in the medical record, it truly reflects the care that we're delivering for those patients. Now, I think really importantly, when we talk about documenting in the medical record, we need to really look across the spectrum. This is physicians, it's nurses, it's allied health practitioners, each of those people that are involved in delivering care to those patients. So to create a documentation culture that reflects the clinical truth, we want to ensure that hospitals are funded according to complexity. And so, you know, Saudi, as you know, is going through a huge transformation at the moment. A variety of funding models is being assessed. So making sure that when those decisions are made on those funding models, that it's done based on a population where the clinical truth or the patient's journey has really been well captured through that documentation. We're also really passionate about enhancing the integrity of healthcare data. And, you know, each of the sessions this evening have referred back to being able to collect data and make decisions on that and have that inform how we may change processes or practices or pathways that we've created. So I think what's really wonderful about clinical documentation improvement in particular is that we can impact on patient safety and quality, patient outcomes, and then the data that comes from those records whereby a lot of decisions are being made. So as I say, we like to empower clinicians to deliver safer care to every patient. If you're really interested in clinical documentation improvement, I would really encourage you to join the CDIA community. There's lots of great information on there about patient safety. You know, a lot of it's delivered by our doctors, by our nurses as well. We've developed a certification in clinical documentation improvement, and I'd really love to tell you a bit about that later on. But really, why is it here tonight, and why are we looking at how do we document diagnoses in order to make care safer? We have worked extensively in the Middle East with the King Faisal Specialist Hospital and Research Centre, with Johns Hopkins Aramco, now the CNHI, which was formerly known as FAP. And we were there just in June undertaking an audit at one of the very large public hospitals as well. So I've got a really good feel for what the documentation in the Kingdom is like. You know, I've been to the Kingdom a number of times and really enjoy spending time over there. So we know that Vision 2030 is around transforming healthcare. And a big part of that is, you know, making sure that patients have access to care. And clinical documentation really does impact right across each of those areas for transforming healthcare. We know that the Sabahi standards really recognise the importance of clinical documentation improvement, and so it's actually, you know, seen throughout the standards as well. So it's really wonderful to see the impact or the attention that's been given to CDI, and really around making sure that we're documenting so that we've got diagnoses to impact patient safety. So when we think about patient safety, we're really looking at how do we make sure the record reflects the care that we're delivering. And as I mentioned before, when you have safe patient care, that can impact on the hospital from a financial sustainability perspective. You know, we know that if a patient falls out of bed and fractures their hip or has a head injury and requires, you know, to go to the operating theatre, that can cost a lot from a financial perspective. But what about the personal cost to that patient and to their family and so on? So it's really important that we look at this not just from the patient's perspective, but also the people around them and the people that care for them. So we've got a real responsibility for making sure that we're delivering safe patient care. We did a couple of surveys, and this is just one of them, and I'm going to share a second one with you. And in this survey, we interviewed 253 clinicians. So you'll see here that we interviewed doctors, we interviewed nurses, and we had allied health practitioners. And when I say interviewed, we were doing hospital-wide clinician education. We were talking about patient safety and quality. We were talking about clinical documentation. And we asked them all just to take a moment and reflect and think about patients that they'd cared for recently, charts that they'd looked at, whether it be a medication chart, whether it was the notes in the record and they'd been asked to send a patient for, an investigation or a treatment. And the question was, when reviewing the medical record, how often is the indication for a treatment clear to you? So while you're sitting there today, have a think about that yourself. Think about patients that you've been involved with and how often the indication for a treatment is clear to you. And pretty, alarmingly, really, here we have almost 70% of respondents saying sometimes or often. And when you think about, that patient in a bed, it could be your mum, your dad, your grandparent, your sibling. You really want to make sure that the people that are delivering that care to your loved one know why they're doing it. I think back to when I was a junior nurse, very young, a number of patients, being really busy, trying to shower, make beds, do a medication round, and I'm talking 30 years ago, having a medication chart and going to give a medication and thinking, I'm not 100% sure why, what the indication for this is, but everyone else has given it. I'm really busy. I think I'm just going to go ahead and give it. Now, I wouldn't do that now, and I certainly wouldn't, encourage anyone to do that. But imagine if our physicians, when they're charting those medications, they documented the indication. What if when a treatment's being prescribed, an investigation is being done, and we've got a link there, a linking language that helps us recognise why that treatment is being given. I remember having this discussion with a group of nurses once about a patient having a catheter go in. They said, they must have had urinary retention. I said, but let's think about all of the reasons why someone may have a catheter. And it may well be that we wanted to monitor their urine output because of their kidney function. So if we've got linking language there about why that patient's got a catheter, that it's due to their, monitoring of kidney function, or, maybe it was due to their urinary retention, and each of the caregivers also understand why that treatment's been given. And that really improves communication. In this group, there were 308 staff who answered this question. When reviewing the medical record, how often is the indication treatment for a treatment clear to you? And you can see again, it's sitting up at about 70 to 80%. So we see that we've got a lot of opportunity here to do things well and to do things better. We talk about 90% of adverse events in hospitals come down to poor communication. And so if we could improve how we communicate with each other through the medical record, be it paper or electronic, that we're able to capture those diagnoses so that the whole team understand why we're doing something. Now, when I talk about capturing diagnoses, this isn't about nurses diagnosing because, they will tell you that that's outside of their scope. So we would never ask anyone to do that. But we would, we'd work with our colleagues, our physician colleagues, and ask them to clarify what's that due to, why is that patient having that treatment. So we asked a group of health information managers, and we said to them, does the current state of clinical documentation at your facility ultimately empower your clinicians to deliver safer care to every patient? And about 60% of them said yes, but you know what? It could be better. 25%, not really. We think there are lots of gaps. And so again, I wonder, smallish sample size here, only 66 respondents, but I wonder if you ask these same sorts of questions at your own facilities, what might the response be? And that'll give you a good idea of what might be going on in your home hospitals. So when we think about improving documentation for patient safety, I really see that there are 4 key areas in which you can do that. And the first one really is around a diagnostic assessment. And a diagnostic assessment allows you to look through the medical record through the eyes of a clinician. And this is something that we do very commonly. We will look through, a number of records, and I'll share just a couple of statistics with you at the moment. And many of you would know about clinical coding, and that happens when a patient's discharged. But while the patient's still in a bed, making sure that that link between a diagnosis and a treatment is made. So when we do our diagnostic assessments, the patients have already gone home. We're looking through that record, through the lens or through the eyes of a clinician. And we're looking through for where the gaps in the clinical documentation are, and therefore a diagnosis has not been documented. So if I share this one with you, this is an audit that we actually did in the Kingdom of 150 records, and we identified opportunities to improve documentation in about 20% of the records. It was a very large hospital, and this was a very small sample, but we identified 110 occasions where a diagnosis had not been documented. And so we would call that inadequate documentation. And if we look then at how common that was, it was across 43 different additional diagnosis codes. So that might be language that you're not necessarily used to. So when we look through records, we're looking for where perhaps a patient has a potassium of 3 and then they've been given a potassium supplement to bring their potassium to a normal range. So 43 occasions across those 110 was where there were gaps in that clinical documentation. And so you can imagine as a junior team, many of you are probably physicians. Think back to your junior days where, doctors are rotating quite frequently. New graduate nurses are coming on. Sometimes there's a bit of a transient workforce with nurses coming over for, contracts and then leaving again. So there's lots of gaps in the way that we document as clinicians. And these baseline assessments that we do help identify where those gaps are. So what is clinical documentation improvement and how can it impact on patient safety? Well, clinical documentation includes all staff. So it's all clinical staff that document in the record. It's about having a collaborative approach. And it's not about questioning clinical decision-making. So it's not about us saying to the physician, why did you start that patient on that medication? It's, can you clarify the indication for the medication? So we're getting that link between a treatment and a diagnosis, but it's not about, the decisions that had been made. So clinical documentation improvement program, they really aim to improve the quality and the integrity of the clinical documentation in the patient record. And that can improve interclinician communication, definitely improves patient outcomes, improves, or impacts on data quality. And, many of you would be aware that the ICD-10, so the International Classification of Diseases version 10, the AM, the Australian modification, has been adopted by the Kingdom. And that's really set down by the World Health Organization. And those codes are used in about 42 countries around the world. So by having really good quality data that's being shared at the WHO level is really important so that we can see what's happening globally. But even at a more local level and even at a hospital level, using that data is, can have a big impact on a wide range of things. So important that we do whatever we can to make sure that the documentation truly does reflect the complexity of the patients that we're caring for. So if we think about then, we've done a diagnostic assessment, we've had a look at what's happening with the documentation. And then what we want to do is have someone called a clinical documentation specialist. Now, these are typically nurses, but can definitely be clinical coders, people from health informatics, allied health practitioners, and they actually go through the record while the patient's still in a bed. And the idea is that they then work with the physicians, the clinicians, to document in the record at the time the patient's still in our care. And what that does is it improves the communication between all of the caregivers. But it also means that when the patient's discharged and that record is read by the clinical coder and assigns those ICD-10 codes, that we're capturing a higher quality data set, which, as I said, is really important. So the CDSs engage with the clinicians. They talk to them about these, what they've identified in the record. I remember doing that audit in the Kingdom and coming across a patient who had about 15 units of blood during their admission. They were pretty sick, but nowhere did I find that documented that the patient had anemia. You might think, well, that seems pretty straightforward. You know, if they're having blood, they're probably anemic. And yes, in that case, you could be right. However, we'll learn in a moment that anemia will never get captured unless it's documented. There's a whole lot of treatments that are being delivered that we don't have those diagnoses for. So the clinical documentation specialists engage with the physicians to get the quality really right at the time, thereby improving patient safety and quality. So part of the challenge with trying to capture these diagnoses are the Australian coding standards, and that's because the coding standards say that the clinical coders aren't allowed to infer, they're not allowed to guess, they're not allowed to see a positive urine culture and then, you know, some antibiotics prescribed and assume that that's a UTI and therefore code that UTI. You know, some of these sound pretty straightforward. If a patient's got a blood sugar, you know, very low and they're given some dextrose, then they've probably got hypoglycemia. And you could be right. But like my example before with the urinary catheter, that may be because their kidney function's off. It may not actually be because of urinary retention. So it's important that we make sure that there's that link anytime that we prescribe a treatment, you know, change treatments, do investigations, that we link those to a diagnosis. And we can really achieve that through a clinical documentation improvement program. Physician champions are becoming very common in hospitals that have got CDI programs. They're often appointed to these roles because they've got credibility among the medical staff, they're active in clinical practice, and they've got well-developed communication skills. We just trained 20 physician champions at Johns Hopkins Aramco. And really their role is to make sure that they are flying the flag essentially for CDI. They're someone that those clinical documentation specialists can ask for help. If clinical code, you know, if queries are being generated, the physician champions can help support that process. But by having these roles in the hospital as well, it really shows everyone at the hospital that you know, that documenting for patient safety and capturing those diagnoses is you know, held in a very high regard. So great to have, as well as those clinical documentation specialists, these physician champions. Part of the clinician engagement is around doing what we call hospital-wide clinician education. And so, you know, at one hospital, we did about 37 sessions across the days that we were there. We had multiple doctor sessions, multidisciplinary sessions, some dedicated specifically for nurses and allied health. And in that hospital, we were able to see 516 clinicians across about 3 or 4 days. So if we go back to why clinician engagement or why documenting the record is so important, and we're thinking that and we're constantly linking that back to patient safety, here's over 500 clinicians who have heard that safety message and are able then to take that back to their clinical areas and really influence each other about the way in which they document in the medical record. This was another group that we worked with where in 2 days we had 87 nurses and 34 doctor sessions, another hospital across 5 days, 385 nurses and 246 doctors in allied health, and then a third hospital. So these were essentially like being within the same cluster. One of the smaller hospitals had 2 days, one of the larger hospitals had 5 days, and then another hospital had 2 days. So essentially what would be the equivalent of a cluster over 9 days, there were 822 clinicians that were involved in that safety message around documenting in the record to capture complexity and improve clinical communication. So we've talked a little bit about the baseline assessment, about concurrent CDI. So that's where the clinical documentation specialists are documenting in the medical record to make sure they capture the complexity, and then making sure we engage with as many clinicians as possible. And I know in the Kingdom at the moment, many hospitals Many of the clusters are looking at how do we improve, how do we make sure that we're capturing this complexity. And I would really encourage you to think about it from these areas. So what's really exciting as well for clinical documentation improvement and documenting for patient safety is that we've created a certification, and the certification has 3 levels. And really what we're trying to do is create a career path. We believe very strongly in CDI, clinical documentation improvement, and we know that there's a lot of clinicians, people involved in healthcare who are as passionate about it as we are. And we really felt that with the Kingdom going through this transformation and really recognising the importance of clinical documentation improvement, that being able to have a certification that's recognised, this one's been endorsed by the Council for Health Insurance, and there's a number of certified CDSs in the Kingdom now. And so in order to become a certified CDS, of course, you need to have some training. There's an exam that you need to sit. And then following that, there's a pathway for those who are going to be actually working in the role as a clinical documentation specialist. And like I said, a CDS is going through the record while the patient's still in the bed. So they're really part of the overall CDI team. And when we talk about a CDI team, it's about having clinical documentation specialists, people from clinical coding, people from health informatics, really working together to create this CDI team, knowing that the goal is our patient and their family at the centre and making sure that we're capturing their complexity. And we're able to demonstrate that through that clinical coding process that we talked about. But sometimes there are 2 different paths that people might like to take. There's those that will be actually working in the role as a clinical documentation specialist, and those who are really passionate about CDI as well, but may not actually be working at the bedside. And so for them, we've created a new pathway that's going to be released early next year to demonstrate their experience and the fact that they've done training in clinical documentation improvement. But essentially there's 3 levels of certification, formal training, sitting an exam, and then for level 2, having more experience working as a CDS, both delivering education and receiving education, and then moving on to level 3, which is really around mastery. I'm just checking my time. So I guess the few take-home messages that I would have for you today, if you're thinking about how you might be able to make a difference from a patient safety and quality perspective, is look at what's happening in your own organisations. Look for those people who are interested, who might be, there's always those people around that you think, they love a new project. They're passionate about, whether it's delivering care or, doing quality projects and those sort of things. So tap into the people that are around who might be interested, and then bring them together and think, what is it that we can do in our facility? And there are lots of different ways that you can impact on capturing diagnoses for patient safety. Make sure you include your clinical coders. Make sure you include, any CDSs that you may have in the hospital already, because it really does take, a bit of a village. They say it takes a village to raise, families, but it definitely takes a village as well to get people involved and to feel excited about clinical documentation improvement and capturing that complexity from a diagnosis perspective. I think, we've all been through a pretty tough couple of years. People are feeling pretty burned out. If you approach some physicians and they just think, I can't take any more, help them understand that by capturing these diagnoses in the record, ultimately it saves them time, because it means that they're not getting contacted, people saying, can I just clarify this? May I ask you that? What did you mean by this? If that's all happening in the record when they're doing their rounds, and often the CDSs can round with the physicians, and that means that the communication's improving, right from that first round that happens. Many of the junior doctors are rotating. They tell me, and our doctors on our team also tell me that often they don't feel very confident themselves to ask those sorts of questions. So again, really important to bring everyone into it and create that documentation team. And I'd be happy to take any questions.
Thank you very much, Ms. Nicole. I believe documentation and having coding for diagnosis is the one of the key steps in improving diagnostic safety. I would like to invite all the speakers on the stage to have the Q&A session. Listen, please. Yes, thank you very much. So, Dr. Hisham with us. Dr. Hisham? I think he left.
أيوة عفوا مرحبا.
Assalamu alaikum, Dr. Hisham. So, thank you very much all for this amazing learning opportunity. And I would like to start the question with Dr. Hisham. So, we have one question for you. So, using your screening prediction tool for the sepsis will help in detecting sepsis, but also will increase mislabeling for more patients. Do you have any strategy or solution for that, or to help on this?
I'm not sure what they mean by mislabeling exactly. You mean?
I think, maybe the question is related to having more patients with maybe mislabeled as sepsis patient, but they are not.
Yeah. Okay. So misdiagnosis or overdiagnosis.
Yeah.
Yeah. Well, of course, there's always a chance that you will be overdiagnosing. There's also a chance that you'll be potentially overprescribing antibiotics. And this is always the challenge when you're trying to, when you have a sensitive tool that picks up patients, that you're going to pick up patients that are, falsely diagnosed as falsely positive. And so you have to put in like balance measures or balance checks to make sure that you're not, misdiagnosing or overdiagnosing. And that's why we do a couple of things. We have a committee that oversees this process. And so reviews are done on a regular basis where we look at the cultures and we look at the indications. And we also look at issues related to antibiotic usage, compliance with the pathway, and also the infection rates or the resistance, antibiotic resistance rates. So those are things that we do to try to, ensure that we're not overdiagnosing.
Thank you very much. And one more question for you. What is the biggest challenges that you could share to implement HRO as a lesson learned?
Well, HRO is really, it's about the culture of the organization. And that's why the biggest challenge is, first of all, to have the leadership input into it. And so it takes a lot of time for leaders. When we're clinicians, we're excellent in our clinical work, but we don't always bring the issue of patient safety and quality in the same way. So, for example, a busy surgeon or experienced surgeon, does their surgery and their job, they believe their job ends when, but really you need to engage those senior surgeons, the leaders, into looking at the high reliability organization. It's the organization itself. It's not just the surgeon, the quality of the work the surgeon does, but the whole organization. And this takes time. That's the biggest challenge. It takes time, and it takes people who are willing to be involved and not expect a quick solution, because this takes time.
Thank you very much. So another question to Engineer Ahmed. So what is the metrics and measures that can assist us to select the right application of technology?
Well, this is depend on the the needs and the infrastructure that the hospital has. Of course, there should be an approval technology from the authority like Saudi FDA. And are you able to adopt it in the system and in the daily clinical use? So there are many technology, and are you able to afford the I would say the cost that it brings to the health to the budget of the hospital, I would say. So there are many factors that can because everyone wants to have the state-of-the-art technology in their to present it to their patient, but they have to consider other consideration. Are they? I mean, is there any? The staff are trained also. The infrastructure are there because if every technology bring some challenges that, as we can, we see in the presentation, especially security and data privacy and other challenges. So make sure that you are ready to, to overcome these challenges and to accept that it needs time to adopt it to the clinical, because clinicians are reluctant to use new technology most of the time because they are used to specific devices or technology. So it takes time to convince them and to bring this new technology into the daily practice.
Okay, thank you, Engineer Ahmed. One more question, I think Dr. Hisham or Dr. Engineer Ahmed can help us on this. So the question is stating it's indeed helpful to adopt AI in making diagnostic decision, but in another hand, can healthcare provider depend on AI or adopt a policy to ensure that this given outcome by the device are correct before proceeding with the treatment plan? Dr. Hisham?
I understand the question. I'm sorry.
So can the healthcare provider depend on AI alone to have the decision, or they should adopt more policies to ensure that the given outcome is correct before proceeding with the treatment plan?
Well, I think at this moment, from my understanding about AI, it hasn't reached the level where it can be working independently from clinicians, and it needs to be more of a support for the clinician decision making. But of course, I'm not the expert on that.
Yeah. Engineer Ahmed?
Yes, totally agree with what Dr. Hisham said. The health technology is not a replacement for a physician, but it supports the decision making. It makes it easy to analyze and gather more information from many sources like electronic health record and medical imaging and doctor reports. So it's not a replacement. The physician and the nurses and the caregiver must give their decision based on this. The AI and the other factors that they are. The patient condition himself.
Thank you very much. So for Ms. Nicole, can you share with us any challenges during the implementing of diagnostic code in the hospitals?
Look, I think there can be challenges with anything that you want to implement. I think when you think about when you're going to be changing things and changing behaviours, we really look at it from 5 key areas. And that's people, helping people understand the reason for change. If we don't bring people along, if we just try to implement something on top of them without inviting them to really understand why it's important, I think that's one of the challenges when people don't do that. I think, we talk about friction reduction. You've got to make things really easy for people. People are very time poor. So anytime that you want to introduce something new, think about, how can I make this as easy for, essentially the end user being the clinician. Reinforcement's very important, and having that clinical documentation specialist, they're the reinforcement component of it. Buy-in, executive leadership is also very important. Making sure that it's really coming from from the top down and the bottom up almost. And then we also talk about imitation. So if we can, like I spoke about, we trained those 800 clinicians. If those 800 people start making a change in the way they document in the record, then other people start to see that that's the standard that's expected in that hospital. And so people start imitating each other and making those links with the diagnoses. So, lots of things are challenging, but if we approach them from a almost an evidence-based perspective, that definitely will help with adoption.
Okay, with that, thank you very much all for your informative sessions, and I would like just to remind all the audience that for the next session, right after this session directly, about the role of patients and families in the diagnostic safety. Thank you very much all, and
Thank
goodbye.
you.
Thank you. Thank you.